Now, it's been a great pleasure to introduce our project as snapshot updates during the IHCC seminars, and it's always been just 5 minutes and 10 minutes to give you all an update. And I firstly want to thank very much the IHCC consortium for choosing this project to fund in the first place. And with great gratitude. I think it's been a fantastic project. And so this has been actually a wonderful opportunity to not just do a 5 or a 10-minute update, but to give you an overview of how we used this funding and how we spent the funding on this project. So I will now share my screen. So can you see my slides? Am I sharing the right?
Yeah, you're in the presenter mode, I think.
Yeah, let me just, can you see my slides?
Oh, no, you need to revert and make full screen, I think.
Okay, is that correct?
Yeah, I think that's right, yeah.
Yes.
Okay, perfect. So basically, we were focusing on the global mental health impact of COVID-19. And this funding went towards, it's a 3-site project, and I'm really presenting on behalf of the 3 sites. In no ways do I take credit for this as a single site project. So I am PI of the Oxford site and co-chair of the IHCC COVID-19 Mental Health and Behavioural Impact Scientific Working Group, said that all in one breath. And working for me were actually, because this work is ongoing, 2 research assistants, a data scientist, Josh, and a research assistant, Meggie. Also, Andre Brunoni in Brazil with Daniel Fittori, a postdoc analyst, and Jordan Smoller, who is co-chair at Harvard with Ashley, Rebecca, Heather, and Lou Zowen. So it was definitely a collaborative effort, everything I have presented here. We're a very strong team, a collaborative team, and we worked across the time zones to deliver this project. So I'm going to talk today about the team, how we work together as a team, the background to the project, the aims, the cohorts we've used, and the strategy, how we actually pulled together this project, the studies that we completed, and also the future for the project. Because if officially the project and its funding has come to an end, the project has definitely not come to an end. We continue with this project. So this is a quote by the UK Mind organisation, who says, our research with almost 12,000 people found that those who were most likely to struggle with their mental health before the pandemic have been most affected. So in other words, it's those people who already had anxiety, depression, suicidal thoughts, and mood disorders before the pandemic hit. Those were the people that were most affected during COVID-19. And I know that COVID-19 has affected all of us. I don't think there's anyone in this room here that can say it did not affect us in some or other way. But those who had pre-existing mental health problems, it affected them even more so. Now, these graphs I'm going to present here, they are taken from the University College London COVID-19 social study. The PIs, Daisy Fancourt and Andrew Steptoe, they have been tracking mental health throughout the pandemic. And this is from report 42, taken in January. So they have tracked people 42 times. And I'm presenting this right in the beginning, just as a snapshot about how the pandemic has affected mental health through the pandemic. So this is life satisfaction as lockdown hit in March. So this is the UK. You can see that people's life satisfaction hit a bit of a slump, and then it started raising as lockdown was eased. It started to raise, and then again, it hit another low as lockdown came in again. Again, it raised, and then it hit again as COVID hit. And so you can see the peaks and troughs of life satisfaction. Again, we look at life satisfaction by age groups, and we can see that it dissociates by age groups. We can see that it's hitting the younger generation more than the elderly because it has an impact on socialization, going to school, colleges, and universities, but the trends are the same. Remember, this is during the COVID pandemic on individuals who've not been tracked before and after. This is everyday people going about their everyday lives. Depression and anxiety. You can see that people are recording, and this is using the PHQ-9, which is a depression scale, and the GAD-7, which is an anxiety scale. So people are recording during lockdown higher levels of depression and anxiety, and as lockdown eases, so the depression and anxiety eases. And so so you can see the trend lines following lockdown easing and releasing over the pandemic. And again, by age groups, we see that it's impacting the younger adults more so than the older adults. Anxiety, again, by age group as well. And an interesting one, and we'll come back to this when I move on in my presentation, is abuse by age group. During the pandemic, unfortunately, domestic abuse was creating a pandemic within a pandemic, with abusers locked down with their victims, abuse increased, and we can see more so within the younger age groups. And this impacted the mental health of these victims as well. And so we move on to our work as well. And I'll show you the reason why I've given you the background of the University College London work in just a moment. So the COVID-19 pandemic has brought about an unprecedented set of challenges impacting the mental health of populations all over the world, with mass unemployment, economic downturns, food and housing insecurity resulting from efforts to control the pandemic has had a knock-on effect on social determinants of health and strained the resources for mental health care. So those at risk by virtue of pre-existing mental health disorders have been cut off from their usual care. Home visits stopped, and I know that that happened in the UK, and so we're just extrapolating here and saying it must have happened all over the world. And also those coming into centres, I work here at the Warneford Hospital, clinics stopped. It was lockdown for patients who were inpatients. Visitors could no longer come along to see the people who are inpatients for psychiatric care. So the unprecedented scale and scope of the pandemic and its fallout meant that the evidence space for optimal prevention and treatment strategies is severely limited. And so all of this was occurring against the backdrop of already rising rates of poor mental health and psychiatric illness all over the world. So the IHCC COVID-19 Mental Health Behavioural Impact and Scientific Working Group is leveraging the unique platform of IHCC Consortium to address pressing questions related to COVID-19 and mental health. So the IHCC brings together cohorts who have gathered mental health from a longitudinal mental health data from millions of individuals around the world. And through the participation of epidemiologists and other researchers with expertise, we are able to address vital questions, not only for this ongoing pandemic, but unfortunately to address future pandemics which may come along as well. So we have managed as a group to harness the power of over 20 cohorts, and this is growing because of the desperate need to answer the questions and address future questions as well. So at the moment we have access to over 1.5 million individuals in this 3-site project, and we had 3 major aims. Firstly, to catalogue and categorise the appropriate cohorts with mental health assessments pre-pandemic and during the pandemic, to harmonise a set of domains and assessments for cross-cohort investigations, and to conduct longitudinal data analyses to address core scientific questions. So our strategy, the full IHCC working group, we've been meeting regularly since January 2021 to discuss project updates, analytical plans and preliminary findings. The analyst group has been meeting fortnightly to discuss the implementation of analytical plans formulated in the previous months. Analysts then contributed to reviewing all statistical methods and interpreting preliminary results based on the feedback given by group members. Analyses were changed then according to suggestions. So we always had a meeting in the diary. Every 2 weeks, we had the group meeting, the analyst meeting, the group meeting, the analyst meeting. And this really did contribute to the success, I believe, of this 3-group project. So our cohorts of interest. Now over here, we have at least 19 of the cohorts. I think it's 19 here listed. And you can see they are from all over the world. We have USA, from Brazil to Finland, Scotland, South Africa, South Korea, Greece, Brazil, Australia, Italy, and Ireland. Some of these cohorts, the members of the 3 group have direct access by nature of the members of the group. So Jordan Smoller's group, for example, have direct access to all of us. As Senior Data Manager for Dementias Platform UK, I have accessed DPUK cohorts such as Generation Scotland, ELSA UK, and I'm able to access them through the access permissions through DPUK and UK Biobank. Andre Brunoni in Brazil is able to access ELSA Brazil directly. Other cohorts through connections and through our wider networks across the 3 institutions were able to reach out, such as MGB and Biobank through Jordan Smoller. And I have been able to reach out through my connections of setting up Dementias Platform Australia. I've been able to reach out to Australian cohorts as well. And recently we have Tilda, the Irish longitudinal study of aging, join us. And more recently, we have reached out to the Qatar Biobank. So this has really been a hard networking opportunity where we have pooled our networking resources. But what we see here is we don't see that it took us actually almost 10 months to pull together these resources and to identify variables of interest. So what we did was we took these cohorts, we surveyed their data dictionaries, their documentation of the core variables that we had access to, and we identified top-level categories. And so we identified that we needed to understand what outcomes, such as depression, anxiety, stress, well-being, and cognition. We were interested in the demographics, such as gender, education, ethnicity, socioeconomic status, external factors, such as housing, jobs, marital status, pregnancy. These were all important factors which influence how mental health status interacts with the COVID-19 pandemic. Social distancing, lifestyle, resilience, such as coping behaviors, perhaps religion, and also discrimination. How is that affecting individuals during the COVID-19 pandemic, which perhaps outside of a pandemic situation, discrimination and mental health and coping in a pandemic would not necessarily be so integrated into our analyses. And then psycho and medical factors, pre-existing psychiatric and medical conditions and how that is affecting both medical health and biomedical health. And then healthcare access and how that affects socioeconomic status, who has access to actually medications, or even now as we move further along in the pandemic, vaccinations. So these, we drew up a template. A lot of the data curation work off the back of the work we do in Dementias Platform UK was led through Oxford University, and we used our knowledge of working with a large a cohort data repository to do a lot of this categorization work in Oxford. So what were the type of questions that we were initially wanting to address? Because we had the data, we'd started to categorize our work. Where did we start? So we knew we wanted to look at mental health trajectories pre and post-pandemic. We wanted to look at socio-demographic determinants of mental health outcomes in COVID-19. And then we wanted to also look at neuropsychobiological manifestations of COVID-19, mental health and cognitive resilience. And more recently, as the project has come to a close, but yet still ongoing, I do want to emphasize that, we are looking now at life course stress, mental health, both pre and during the pandemic. So I'm now going to tell you a bit about the work that we have actually managed to complete and submitted 2 papers for publication. So this is a paper that has been led out of Brazil, led by Daniel Fattori, the postdoc under Andre Brunoni. So this is trajectories of common mental disorders before and during the COVID-19 pandemic using ELSA Brazil. So using a group-based trajectory modeling analyses, he conducted in the context of ELSA Brazil, a cohort study on 2,705 members of the cohort. Data was collected across 2017 to 2019 during the pandemic in May to July 2020, and again in September 2020 and October to December, and again in 2021. The following groups were identified and labeled according to levels of symptoms and shapes of trajectory. Group 1 had low symptoms of mental disorders. Group 2 had low decreasing symptoms. So this is decreasing symptoms of mental health through the pandemic. Low, and then group 3, low increasing symptoms. Group 4, moderate decreasing symptoms. Group 5, low increasing symptoms. And group 6, severe decreasing symptoms. And the aim of this project was to understand who, and the reason we need to know this is to understand who is at risk of having increasing mental health symptoms during a pandemic. And this is the more complex statistical bits, which I won't go into too much details, but he used multiple imputation by chained equations. And what this did was this made up for the fact that not everyone completed all questionnaires at every time point. And this was to determine, and he ran this through, and this determined the fraction of missing information, the FMI, which indicates the proportion of total sample variance. And the reason these clever methodologies are really important in this type of work is this enables us to use multiple time points across cohorts, which perhaps have collected data points where there's missing variables, there are different questionnaires. And so sometimes when people say, do you harmonize, do you not harmonize, how do you use different cohorts and different measures? Sometimes it just takes a very clever analyst to do clever methods to get to what we need to know. And this is exactly what Daniel has done. And again, we used multinomial logistic regression to investigate predictors of these trajectories. He ran separate models to understand each predictor, adjusting for sex at birth, age, education level, and also skin color. So over here, I realize it's very small, but the outcome was the results of the predictor analysis showed that groups 2 to 6 were negatively associated to female, gender, and previous mental disorders. Higher income decreased the risk of group 6 membership, but physically active more likely to have severe decreasing symptoms. And participants with adverse life events were more likely to present moderate decreasing, low increasing, and severe decreasing symptoms. This paper has been submitted now, and so I'm not going to keep going into all the statistical details, and you'd be able to hopefully read it soon when it's published. But what this work does is it really importantly highlights different trajectories of how different people with different mental health disorders cope with the pandemic. A further paper, which has come out of the Harvard group, led by Heather Lee under Jordan Smoller, is looking at the effect of perceived discrimination on depression and suicidal ideation during the COVID-19 pandemic using the All of Us cohort. And so this is a longitudinal cohort recruiting over 1 million individuals in the United States, and it investigated the impact of perceived discrimination. Now, as all of us are aware, discrimination it is perceived in many different forms. And so what this study did, it looked at overall discrimination and also racial discrimination. And so notably, Asian and Black participants were more heavily impacted by perceived discrimination if the main reason was due to race or ancestry, particularly in the earlier phases of the pandemic. Furthermore, at higher levels of perceived discrimination, the likelihood of depression was similar among those with or without a pre-pandemic mood disorder diagnosis. To our knowledge, this is the largest and most diverse study examining the complex dynamic relationship between discrimination and adverse mental health outcomes during the COVID-19. And here we can see the variations in the effect of perceived discrimination on moderate to severe depression by the main reason of perceived discrimination, self-reported race, and survey timing. And the reason that I'm going to click through this because we have an important factor that we integrated into this was survey timing, because we wanted to account for political events that were going on in the United States during the time of the survey being administered. And so we took this survey timing during May, June, and July. Now, this is actually submitted now on medRxiv. And so rather than me go into all of these details, this paper is available to read on medRxiv and has been submitted to a journal for publication. And here we can see very easily that variations in the effect of perceived discrimination on moderate to severe depression using the PHQ by pre-pandemic mood disorder, which is any reasons and due to race or ancestry. So I do invite you to go and look at that paper. Now, the third paper that is now underway, which we hope to submit in the next couple of months, is the harmonization of a common core variable data set. Now, this data set will be for our ongoing work. And it is a really important piece of work because this will enable us to do cross-cohort work. And we have made a list of common variables, which was selected and agreed on by consensus across the 3 groups. And the preliminary work will be used in a study using ELSA UK, UK Biobank, ELSA Brazil, All of Us, HRS, and TILDA, the Irish longitudinal study. Here is the first half of the list of variables. And we have selected them to represent across socio-demographics, psychological variables, and also our outcome variables. We have selected harmonization rules. And so we should be able to extract these variables across these 5 cohorts to run a cohort comparison study. And the study that we're going to be focusing on, and these are the rules which I have inserted in brackets. So for example, face-to-face contact will just be a binary yes, no. Have you had face-to-face contact? COVID diagnosis, were you diagnosed with COVID? Yes, no. Cognition will be a standardized score. So these rules are available. We're going to be publishing our rule book. And we're going to be running a study, which I will mention a little bit later on. But this is not without its difficulties, because here is an example from ELSA UK, and this is prospective memory. And this here on the left is unstandardized. And here on the right, we've tried to standardize it by doing a log norm. And you can see that sometimes scores are just difficult to standardize. And here the next one is a prospective memory. On the left, we have the raw data, and on the right, we've tried to standardize it. And so this is a work which is going to take us some time, and it will be an ongoing project to harmonize these data sets across a very disparate and heterogeneous cohorts. I'm running I'm still a couple of minutes. So the work, which is future collaborative work, because we intend to take our project forward across the 3 sites. We are engaging with a COVID platform here in the UK, where a proposal has been accepted to do a cross-platform collaboration investigating the effect of life course stresses on cognitive status on mental health outcomes during COVID-19. This will be on 5 cohorts across 2 platforms. We are also, the work that I previously referred to using the Harmonise dataset will be looking at life course stress and mental health. And then further, we'll be looking at the investigation of mental health and abuse, both pre-pandemic, during the pandemic, in a collaboration with University College London COVID-19 social study and IHCC cohorts. So we'll be looking at specifically mental health of those who've experienced abuse. Rather than just simply abuse, it will be the mental health of those who've experienced abuse. And one of the models, just to explain what we'll be looking at in life course adversity, is here is an example from ELSA UK, where in wave 3, they have measured early adversity, depression and anxiety. And in a preliminary analysis, they repeat the depression and anxiety for COVID. And we find that those who experienced early adversity, who reported that they had early childhood adversity, had a higher level of depression and anxiety at wave 3, and also during COVID as well. So we will be looking at the hypothesis of a cumulative stress load and predisposition to poor mental health during a pandemic. We also have initiated a collaboration with the Qatar Biobank, and we will be looking at the mental health of those who've experienced COVID, and in comparison with ELSA UK, those who've experienced COVID positive specifically. And we will be looking at focusing on an interesting comparative study between the UK and Middle Eastern cultures with experiencing COVID-19 and mental health. And that's all. I hope you enjoyed a synopsis of our project, and I'm happy to take any questions.
Thank you very much, Sarah. That was excellent. Congratulations to you and the team. It's an impressive effort. It's just amazing what you've done in so little time. Questions? Well, Jeff?
Yeah, I'll start. First, I want to also echo congratulations, Sarah, for pulling this together, particularly during the pandemic, which adds both data to your study, but also makes it challenging to carry out, I imagine. So one of the things I was wondering is that the power of the IHCC platform is to increase statistical power and get you higher numbers for your analysis. But I'm also wondering if you, and maybe you said this and I missed it, are also looking to parse your analysis by geography, socio-demographic groups, within country, or I'm just wondering, if you're doing analyses both as of the combination of the cohorts, but also to look at how they compare individually, because they are quite different. That's my question.
Yes, I think that is phase 2, really. That is what we would like to do now. So I think that power is not a problem, as you quite rightly said. It's quite a popular project in that people believed in it. But what we would really like to do now is compare across cultures and countries, and also socioeconomic status and racial inequality. And so this, the project that we would be doing, for example, with Qatar Biobank, we would like to invite other socioeconomic status and low middle income countries to join that project. And I think that is the aim of almost part 2 of our project, is to start stratifying our work, definitely.
Thank you.
So Pabayo has a question in the chat. I can read it, or unless Pabayo wants to talk. Okay, I'll read it. Pabayo?
Yeah, go ahead. You can read the question.
All right, okay. So he says, you mentioned race ancestry as a discriminatory marker. I am wondering about other identity markers such as gender, class, sexuality, etc. For example, how did women of a specific and all races fare with their mental health during the pandemic?
So in the paper I reported from Brazil, they stratified discrimination also by gender as well. And they found there were differences between women, and there was a gender difference. And I'm happy to, I think they have submitted that as a preprint. And so what we did was we looked at discrimination, not only racial, we looked at socioeconomic status, gender, racial, and we tried to look at every aspect of discrimination rather than just racial. Yes.
Okay, thank you. Ronlin?
Yes, very nice job, very nice work on this one. This is really a demonstration project for IHCC to put all together the cohorts over the world to look at the pandemic. I think now, Sarah, you mentioned that there are 2 papers published soon, or 3 papers published soon. So I listened to that. There's almost the 3 papers are individually. Some of them combined some cohorts. So when we should expect the whole IHCC, including more cohorts as together as one publications. So is that when we expect that to be done?
I'm not sure if I understand, but so one paper has been submitted to a journal that's gone out to review. It is also as a preprint under medRxiv. Another paper has been submitted to a journal as well, so they're hopefully under review. The harmonization paper is still it's still being constructed because it's more complex. We are also writing up a project profile paper. So in other words, it's like a cohort profile paper, because we believe this project has been fairly complex and comprehensive enough to warrant a project profile paper. And I'll be leading on that, and I'll hopefully be starting that in the next week or two.
Okay.
And that will be submitted. It will come to IHCC for approval, of course, because we think it deserves a paper.
Yeah, definitely. That's definitely for IHCC and for the other researchers. Look at how we bring the IHCC's all this cohort over the world together to work together, and also what the challenges that is very worth to publish that, and how the challenges will face and how we overcome that through this mental health study. So I think very good. Nice job.
Thank you.
So Sarah, I have a question. So the on the graph that you show the recovery after a lockdown, is the recovery speed always the same, or do you think as people get used to multiple lockdowns they recover faster? I guess that's the first question. And the second question is, would not be interesting, well, perhaps would be interesting to try to design interventions in case that there are more lockdowns. Well, hopefully there won't be more this time, but what it is that we could do to actually improve the life of people that actually get down or more down than the rest, I guess. That's the question.
So I think when I look at the trajectories, I think that it seems to me, I can't say whether there's a significant difference. I'd have to ask University College London, because they're the ones, and I must say all credit to them for those graphs that I presented, and we are working closely with them for future work. They are willing to, they want to work with us. I don't know whether people are becoming accustomed. Oh, it's another lockdown. Oh, I think I'll be okay because my mental health, it wasn't a catastrophe. I think I can recover. I don't know whether people are getting used to it. If I look at the trajectories, it doesn't really look as if, it looks sort of as if people are managing it. But I think that what it can do is that it can highlight management from people such as where I work. I think we need to have things in place for people with mental health problems. We can't just say, well, we're shutting the wards, no visitors, no health visitors, and we've got to start having things in place. And I think that data like this will start showing them that, look, you've got to have things in place. You can't just let everyone swim at sea who has a mental health problem.
Yeah, totally. Hey, Jeff, do you have more questions?
Just one other comment. I see Carlos Garcia is here from our Data Atlas and Infrastructure team, and I'm wondering whether there's a possibility of extending the data harmonization methods that you've used to other cohorts that may not have participated in the project, but who obviously may be interested in collecting mental health data going forward. So it's just seems like you've done a great job with the cohorts that signed on in 2021, but going forward there still may be other cohorts in the IHCC that would like to contribute, and your data harmonization methodology would seem to be quite important.
Hi everyone. So yes, our harmonization is based on the Gecko, and at the moment it has a number of terms that are the ones that are harmonized, and it would depend. I don't know by heart now how many mental health, for instance, terms has the Gecko in it, and this is something that we can consider to expand the terms that we have now in the Gecko, to be able to introduce more harmonized terms into the Atlas. This is something that can be considered.
Excellent. More questions? Anyone else? Latifa?
Thank you, Albert, and thank you, Sarah, for this great presentation. I just have one maybe comment or question. It is, I mean, those challenges that you have mentioned about the depression, about the, all this, so the abuse and so forth. Did you get the chance to share this information with health departments in order to be prepared for if we have another lockdown or another pandemic in the future?
I think that once we get the papers out, we do have the opportunity to do that. And I think that because we're working with IHCC, because we're working with DPUK, because we're working with the University of Oxford, I think there, and John Gallagher, we have the potential to say, look at these papers, we're working with University College London. These are high profile cohorts. These are high profile papers and studies. We have the potential to bring together our findings and, and lobby. And it's all about that. If you can't make an impact and make a change to policy going forward, then what is the point? So I'm all for that.
Yeah, that's what we go to raise awareness on these issues beforehand and get people ready, politicians, decision makers, and so forth. Thank you again.
Okay. Okay. So if there are no more questions, probably close the meeting today. So our next seminar is on the 28th of February, and Michelle Ramsey and Andrew May are presenting. So that would be also a very exciting seminar. I hope to see many people there.
Bye-bye.
See you. Thank you very much.
Very nice.
Thank you.
Bye.
Thank you. Bye.
Bye. Bye.
Everyone.